When those units fill, the overflow moves to high dependency units, designed for lower acuity cases.
ICU, by definition, is a specialized department of a hospital where care is provided to the most critically ill patient. So it's a highly specialized unit that has specialized medical equipment, highly trained medical staff, and they provide care to the sickest of the sick amongst us. And there are different levels of ICU. So the World Federation of Critical Care and Intensive Care, all right, as well as the World Health Organization, will tell you that there are at least 3 levels of ICU. Those are referred to as level 1 ICU, which will just provide basic monitoring, and in some institutions they might refer to them as a high dependency unit in some instances. They provide just basic monitoring to these patients, and then there are level 2 ICU, where it's a step above level 1. They can support certain organ systems of the body. They can provide things like what we refer to as like inotropic support, vasopressor support, central venous monitoring, etc. And then there's level 3 ICU, which can give you multi-organ support. So you're really talking about patients who are extremely ill, or patients who require complex surgical procedures, cardiac surgery, complex neurosurgical procedure, complex vascular procedures. So these patients will require level 3 ICU. Beyond that, there are, of course, a very different classification process for the pediatric patients. And so ICU can also be general ICU, or they can be specialty ICUs. So you have things like the neonatal intensive care unit or the pediatric intensive care unit. In some jurisdictions, especially in North America, you might have things like the cardiac intensive care unit, neurointensive care unit, trauma ICU. So there are different categorization.
You would have, say, that the PROMAC units were supposed to be maternal high dependency units. Many of them are non-functional. So yes, you may say that there's a HDU at Spanish Town Hospital maternity ward, the PROMAC unit. I don't think that's functional now. St. Anne's Bay, similar situation. So many of them have been repurposed for being overflow. Then you have the creation of these makeshift high dependency units in the recovery areas where patients going in and out of surgery would normally rest. And in a situation like that, what happens is that sometimes when you have patients tied up, even inside the operating theater, the anesthetic machine, when you finish surgery, you can't extubate the patient, take out the tube, they have to just stay there on the theater bed until you can fly them out to an ICU space. So you back up all of the operating theater list, and this is especially in the rural hospitals. So HDUs pop up as the needs arrive. You can't say, hey, we don't have the HDU capacity. If you have a theater ventilator, that operating theater becomes the high dependency unit.
That gap is not a statistic. It is a lived crisis.
Patients come from St. Mary because the board of St. Mary and St. Catherine, Clarendon, Kingston, and St. Andrew. Patients will come to the Spanish Town Hospital. We know that because of the addresses that we get.
We're a blended ICU. We have medical patients, surgical patients. Our department actually cares for obstetric patients and gynecology patients as well. We're a hospital complex. It's the KPH and the Victoria Jubilee Hospital. So because we're a tertiary institution, we do care for any kind of case, essentially. Anybody who is critically ill, so any patient who has an organ that needs to be supported, we'll care for them. We're primarily surgical, so maybe 70% of our admissions are surgical. Victoria Jubilee has their own ICU HDU area now, so they care for their patients. Sometimes we see those patients in our ICU, but most of the times when you're critically ill, you manifest in your lungs not working or your heart not working, your kidneys not working. So we will support patients, help them to breathe if they have what we call respiratory failure. If they have major overwhelming infections, so infections of the whole body, inflammation in the whole body, we'll attend to those patients. We see a lot of trauma in our unit. About 30% of our admissions are related to trauma, both accidental and non-accidental trauma. So, head injuries, motor vehicle accidents, compound injuries, we'll see that and attend to that. But I mean, we manage people with severe asthma, diabetes that has put you at the brink of death, that kind of a thing. Very severe viral infections, pneumonias. We help people through that.
We'll be right back. "23 high dependency areas have been carved out to catch the overflow across the public health system, and 19 recovery room spaces to ventilate patients for a short, fragile window of time before they must be moved. Stretching them beyond their purpose introduces clinical risk."
The outcomes are going to be worse. If you're fortunate, the patient is fortunate, they may pull through because, again, you don't have the resources, you don't have the monitoring. If you have somebody in an HDU who really and truly should be in an ICU, their risk of infection goes up. The risk of having undiagnosed complications, those go up as well because in an ICU. And then, of course, the level of care that you have, because in many rural hospitals that are functioning with makeshift HDUs, they don't have the full complement.
Equipment is limited. Staffing ratios differ. Some major facilities operate without a single dedicated ICU ward. Spanish Town Hospital serves one of the island's largest urban populations, yet relies heavily on high dependency care.
Based on the ratio as it relates to crit care patients to, it's really 1-to-1. And the most they will go is 1-to-2. So if it is you are managing 3 patients in this space, you really should have 3 crit care nurses to manage, but at least 2 in the space to manage 3 patients. Likewise, the neonate, you have, the babies really should be 1-to-1.
Savlamar Public General Hospital, covering communities in the Western region, faces similar constraints while treating a steady stream of severely ill patients.
When we need that next level of care, and we're looking at relatives and their loved ones, and we're saying to them, this is where we can't do anything further for the patient because the patient needs 1-to-1 intensive monitoring. Those relatives now bear that emotional burden. It's a significant emotional burden within the community to not know where your relative is going or how they're going to access this care. The truth is, even with these trying to transfer the patients is difficult because the majority of the times that we consult one institution for transfer, they're at capacity with their ICU, no beds. The ICU beds in general, they're few. And so we end up calling many hospitals of the 3. And sometimes, when I say many now, we're talking about even asking relatives to find private intensive care units to house their relatives. It is challenging because SAV already functions with a staff complement that is below what it should be. Organizing patients for transfer in the middle of the night, early morning, whenever, it's a tedious process. It involves organizing staff to go with the patient, transport, which we do have a problem with transport, or ambulance services or ambulance numbers or the capacity of our ambulances are reduced, or airlift these patients, which is expensive. So most of our patients who need critical care now will have to be airlifted to Cornwall, KPH or to University Hospital. So it's a challenging procedure to be transferring patients.
At the University Hospital of the West Indies, the island's premier teaching institution, there are 10 operational ICU beds, though physical space exists for nearly 16. The limitation is not infrastructure alone, it is personnel. There are 37 critical care nurses at KPH, some in administration and over 20 of that number in ICU. But more specialized nurses are needed for the unit to function effectively.
Over the years, we have seen a lot of migration. Maybe 3-4 years ago, we had a lot of nurses leaving the island, Jamaica, to overseas for the development. However, we did not get such greater impact because the Ministry of Health at the time, they had what we call a parallel program. So we were training nurses in the field of intensive care to fill that gap that we experienced. Now, that training helped to supply that shortage for the nurses who had migrated. We still do training, but not under the Ministry of Health and Wellness anymore. That program has now been shifted to University of Technology. So we train nurses from the entire island of Jamaica so that they can go to their respective parishes to care for those persons who are very ill.
So in terms of our critical care nurses, we have 21 on staff. And of course, they would serve the accident and emergency, the operating theatre, and the HDUs.
How many more you would need?
I would say 20 more.
I started in ICU in 2005, and that was shortly after we had the second ICU. Prior to that, it was just one ICU. I came to ICU because most nurses will tell you ICU is one of those areas where you get to practice at a very high level. So you are trained to care for patients who are critically ill, and it kind of pushes you, tests your skill, causes you to, be a little bit more interested in learning and, improving yourself. It's the most ill patients, but the challenge is good and the knowledge is really good. So that was my main reason for coming to ICU. At the end of the rounds, we'll have a discussion about the referrals for ICU. And usually we talk about not just within the hospital, we speak from outside as well. So the patients that were referred, say, from Black River or Princess Margaret or St. Ansby, we have that discussion. At the end of that discussion, we need to make a decision about the space we have and who we can take. Sometimes we take the patient not because the patient is the best candidate for ICU, but there are other pressures then, things that, persons will say, oh, this patient has to come because. So on a daily basis, minimum 5 referrals at least for ICU.
And how many of that 5 you will take?
Sometimes we can't take any. Remember, these are persons who are referred, then there are patients who are not referred. We have operating theatre which goes on every day. And from the elective patients that are done, some of those patients were not planned ICU admissions, but for whatever reason, they will need ICU admission after their operation. We do a mix. We actually work flexi hours in ICU, so we do a mix of 12 and 8-hour shifts. At all times, there is a nurse with the patient. Doctors come and go, they go see patients, they come back. The physiotherapist comes, they see the patients, they go. But the nurse is there constantly with the patient. So if you walk into any of the units now, you probably don't see a doctor there, probably don't see a physiotherapist there, pharmacist, but you will see a nurse. We could admit a patient every day if we had staff, because technically we have 18 beds. We have 2 ICUs. ICU A is able to technically house 10 patients on paper, and ICU B 8 patients. So that's 18 patients if we had the staff. So for all the referrals we get, and every day there's at least 1 patient needing ICU space that's in the hospital, and at least 3 or 4 referrals from outside that need ICU care. We always have referrals. We get referrals from every hospital in Jamaica and from Caribbean islands as well. So we have our own patients to pay attention to, but then we get referrals from outside. But on a daily basis, it really is dependent on your capacity. And capacity means the availability of a bed space, which is not just a bed and a ventilator. It needs a nurse, it needs all the monitoring the patient requires. So it is dependent on what is happening in the unit and the availability of a space.
Let's take it to a facility that does not have an ICU but has critical care nurses. There is a motor vehicle accident, God forbid, and a patient has been intubated. You would have already completed 6 or 7 hours out of your work shift, but because of the intricacies of this stage, you are now asked to accompany this client on an ambulance to another facility to facilitate a transfer. That becomes an added burden for the nurse. So there are those who have the train of thought that we work to make ours for ourselves. But think of a nurse with her family and should have made arrangements to go to work 7 o'clock and go home 3. So maybe her husband would have taken the kids to school this morning and she gets off at 3, husband gets off at 5. So she should have been the one to pick up the kids. When you put her in a position where she now has to continue the shift, because remember I said she can't just get up and go. Psychologically, what have you done to her?
To get your voice heard, to be a part of the decision making, you almost have to force your way. Sometimes it's really in the best interest of the patient, so it's almost like you're continually fighting for the best outcome for not just you and your colleagues, but for the patients. Basic things like the infrastructure, somewhere to take a break, not always available. And so many persons leave, not because of the salary, but because of what they can do and become. The scope for advancing in nursing in Jamaica, it's a very slow process.
Without sufficient critical care nurses and specialized staff, empty rooms cannot safely open. On some days, administrators report receiving up to 10 urgent requests for admission and accepting none.
If they have a severe stroke or severe head injury, they usually stay a long time. We have found that, for example, in aneurysm treatment, the patients who have had a bleed from their aneurysm who get into the ICU early, their ICU stay is measured in a matter of hours, meaning they get their surgery, whether they get an endovascular coil treatment or they get an open surgery and clipping of the aneurysm in our hands as a specialty firm who does brain aneurysm surgery. Patients do very, very well when they go into surgery in a good condition. They go into ICU after surgery. After a couple of hours, they can actually get mobilized to the ward, which frees up the ICU space for another patient. On the other hand, patients who are very ill automatically, because of the nature of their condition, they will have a prolonged stay. So say, for example, the same aneurysm patient, if they can't get ICU space early because there is no ICU space available, and then they get further bleeding in the brain and now they are critically ill, that same patient, instead of being hours in the ICU, will be days, weeks, or maybe even months. So those are the kind of paradigms that we are advocating, that we look at in terms of how we approach the ICU.
In terms of capacity,